I think Dr. Faiz का link down हुआ है, so I will just give the introduction. So, Assalamu alaikum everyone, and welcome to the first virtual journal club, which is set in by Journal of Pakistan Orthopedic Association. We are very pleased to announce this new initiative. The main purpose is to engage residents and young consultants in an academic research activity. And of course, all of us are already doing journal clubs in our wards, but this essentially take it to the next is meant to take it to the next level, so that we can promote the authors of authors which are locally and being published in JPOA. So Dr. Faiz will give the welcome.
Bismillah Rahman Rahim. I welcome you all to this first JPUA Journal Club, and I'm very thankful to Professor Owais, Dr. Aisha, and Dr. Imran being here. We will start with this JPUA first Journal Club with recitation of the Holy Quran, and that will be followed by a brief introduction by Dr. Aisha. I'll request Sayyid Saad to recite two verses from Holy Quran.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. لله ما في السماوات وما في الأرض وإن تبدوا ما في أنفسكم أو تخفوه يحاسبكم به الله فيغفر لمن يشاء ويعذب من يشاء والله على كل شيء قدير. آمن الرسول بما أنزل إليه من ربه والمؤمنون كل آمن بالله وملائكته وكتبه ورسله لا نفرق بين أحد من رسله وقالوا سمعنا وأطعنا غفرانك ربنا وإليك المصير. لا يكلف الله نفسا إلا وسعها لها ما كسبت وعليها ما اكتسبت ربنا لا تؤاخذنا إن نسينا أو أخطأنا ربنا ولا تحمل علينا إصرا كما حملته على الذين من قبلنا ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين.
Jazakallah. Over to you.
Thank you very much. The concept of the Virtual Journal Club is to give a local author an opportunity to present on a defined format in this virtual mode. The presentation shall last for the first 30 minutes, and then we have invited an expert to give the review on the particular topic. Every first Saturday of the month shall be dedicated for this academic activity. Dr. Faiz, who's the editor of JPOA, and myself, I'm the managing secretary. We are going to be the moderators. And we will encourage residents and young surgeons to participate. And it's also a good thing that POA is going to grant CME credits for this academic activity. So without further ado, I will like to invite Dr. Imran Haider Kesarani. He is Assistant Professor of Orthopedics at Bahawalpur Victoria Hospital. He did his FCPS in orthopedics in 2016, and afterwards he has done 3 arthroplasty fellowships, 2 from within the country and 1 from abroad. He's very much academically oriented, and he's also completing his master's in medical education. So over to Dr. Imran Haider.
Thank you very much, Dr. Aisha. First of all, I would like to thank the entire board of the Journal of Pakistan Orthopedics Association, including Dr. Faiz, Dr. Aisha. I would also welcome and thank Professor Syed Muhammad Awais for sparing time. He is no doubt teacher of teachers, and I've known him for many years. In fact, I have had the opportunity to meet him at Multan. Probably he won't remember, that was many years back, and I was a resident then. And I have the honor to use his frame by the name of NA fixator, and we routinely apply it at our orthopedic center at Bahawalpur. Thank you very much for the opportunity. Without further ado, I think I will proceed with my presentation. I think my screen is visible to all, right?
Yes, yes.
Right, right, thank you. My name is Dr. Imran Haider Kasrani. I am working as Assistant Professor of Orthopedics at Bahawal Victoria Hospital and as a consultant in orthopedics at Kasrani Medical Center, Multan. As said, I'm a fellowship, a National Arthroplasty Fellowship from Karachi under current supervision of Professor Syed Shahid Noor, Professor Zaki Idris, and Professor Muhammad Umar. I have another national fellowship from Ghurki Trust Teaching Hospital under supervision of Professor Amir Aziz, Professor Shehzad Javed, Professor Naeem Ahmed. I have an international fellowship in joint replacement from Taiwan, and currently I am finishing my master's in health professions education from Rifa International University. Right. These are the pictures of my 2 centers where I work, Quaid-e-Azam Medical College and Kasrani Medical Center. Right. First of all, I would also briefly give introduction of my co-authors. Along with me, Dr. Kashif Siddiq Rame and Dr. Zulfikar Ahmed helped me a lot regarding various aspects of writing of this article. Both of them are working as assistant professor at Bahawal Victoria Hospital. Likewise, Dr. Iqbal Buzdar and Dr. Irfan Ali Shuja, they are senior registrars of orthopedic surgery at BVH, and Professor Ghulam Haider Kasrani, who is my teacher and my father, and is my guide at Kasrani Medical Center, Multan. Regarding the article title states that it is direct access to the proximal posteromedial tibia for the fixation of large posteromedial tibial fractures utilizing the Lobenhofer approach in the lateral decubitus position. So here we have focused upon the approach, the Lobenhofer approach, and that too in a position which is not conventionally used. Normally it is done in the prone position. We have attempted to do it in the lateral decubitus position. And while I was writing the article, and I had to go through the literature search, and I went through various databases, Park Medinet and all the local databases, I could not find a single study on the topic in the region, especially in South Punjab. And I think I could not locate even a single study in the entire country. The posteromedial tibial plateau fixation has always been a dilemma, and regarding various classification systems that have been proposed to help us regarding the management and to classify such fractures, the routine classification that we use is Schatzker classification. I will briefly touch it in the next few slides. However, there are other classifications like the Hall and Moore and the AO classification system. And the 3-pillar concept of the tibial plateau, the proximal tibia, has also gained importance and is of much consideration while you are considering the fixation of the proximal tibial fractures. The posteromedial tibial plateau treatment has always been a matter of dispute, and it has always ended up in being neglected with its associated problems. Now, this is the 3-pillar concept. Previously, what we did was we divided the proximal tibia medially and laterally. That is the medial plateau and the lateral plateau. We did not pay any attention to the posterior aspect of both of these plateaux. According to the three pillar concept, the tibia is divided into a medial column, that means an anteromedial column, a lateral column, which is a anterolateral column, and then the posterior column. The posterior column is also further divisible into a posteromedial and a posterolateral column, so as to say. So this is the three pillar concept and the recommendations for the fixation of tibia. It is said that all the three columns have to be taken into consideration while we are planning the fixation, so as to come up with a good congruency at the level of the articular surface. Now, for the introduction, the proximal tibial fractures, normally they result from high energy trauma, like the road traffic accidents. And as I said, the Schatzger classification is one of the commonly used classification systems, along with AO classification system and the Hall and Moore classification system. It has been observed that the posterior half of the tibial plateau fractures are similar in configuration like the Hoffa fracture for the distal femur. That means the coronal splits in the distal femur, as they occur, the similar type of fracture patterns can be encountered and are encountered in the proximal tibia as well. This is just like one can say the counterpart of the Barton fractures for the wrist, and this happens at the level of the knee. The posteromedial fracture of the proximal tibia, it has been reported to be present in nearly 1/3 of the bicondylar fractures, and according to the Hall and Moore classification, it is classified as Hall and Moore type 1, and it has to be fixed and taken into consideration as a separate fragment. The treatment of bicondylar fractures normally include non-operative immobilization if the fractures are undisplaced. But in recent and modern orthopedics, the trend is more towards fixation and getting early range of motion and getting the patient on feet as early as possible, and also trying to avoid the fixation of the joints for longer periods of time. So for that purpose, bicolumn plating as well as the Ilizarov ring fixator constructs have also been used for this particular type of fracture fixations. The medial plateau, it bears nearly 60% of the body weight, and it is usually fractured vertically as a large piece posteriorly. The fractured fragment then tends to displace posteriorly and also tends to displace inferiorly. It tends to sag down. And attempts to fix this posterior fragment have been carried out in the previous options which I mentioned. Normally, what people do, they approach such fractures from the medial approach, and they apply a T-plate, and only one of the two screws at the most gets hold of that fragment which is present posteriorly. The other techniques that other orthopedic surgeons normally do is they pass antero-posterior screws. Yani from front, the screws heading posteriorly so as to get hold of the posterior fragment. These are the techniques which are commonly used for this particular type of fracture fixations. However, the fracture fixation through the posteromedial Lobenhofer approach, it preserves the popliteal muscle, it preserves semimembranosis and medial gastrocnemius, which are usually sacrificed in other approaches through the back to fix such type of fractures. The Lobenhofer approach, it requires very less soft tissue dissection and allows for accurate reduction and stable fixation under direct visualization with the advantage of good buttress of a plate of the fractured fragment, and allows for very early range of motion. A brief revision of the Schatzker classification. It has 6 types. The type 1 is a vertical split in the lateral plateau. The type 2 is a fracture along with a central depression, and type 3 is a pure central depression. Type 4 is fracture of the medial tibial plateau with or without the fracture of the tibial spine or of the central elements, but the lateral pillar is intact. The type 4 is a bicondylar fracture in which both the condyles are fractured, but the central shaft is continuous way up to the level of the joint and is continuous. For the type 6 fracture, it is a bicondylar fracture with the central shaft element also broken, so as to say that there is a dissociation at the level of metaphysis and diaphysis. The Hall and Moore classification, the type 1 is the one which I am talking about right here. It is a coronal split of the posterior tibia. It is just like the Hoffa for the distal femur. The type 2 is an entire condylar fracture. The type 3 is a ring. Type 4 is is a compression of a rim. It sort of compresses down and bursts open. The joints appears to be subluxed, but actually it is the bony fragments which have sort of compressed and moved slightly laterally. And the last one is a 4-part fracture. All right, so regarding the study, we carried out, the methods for the study is that it is a descriptive study. The study was carried out at Kasrani Medical Center, Multan, and the duration for the study is nearly 3 years. We carried out this study from January 2017 to December 2019. The study sample was, of 15 patients, 15, and the data was collected from these patients at their initial visit to the hospital after trauma, and then at their repeated follow-ups. A pro forma was filled after examination of the patients, after getting their x-rays done, after doing their physical examination. The data analysis was done on SPSS 22, and the ethical approval was taken from the Institutional Review Committee of the hospital. Inclusion criteria for the patients who were selected in the study included all adult patients with proximal tibial fractures and large posteromedial fragment of the medial tibial plateau, or in combination with the other condyle, that means the bicondylar fractures. Intact skin, by intact skin, I also mean that healthy skin, abrasions or too much swelling, these patients were not taken into our study sample. Patients from both genders were taken in for the study. The exclusion criteria included open fractures because likewise, the patients with compromised skin over the fracture, patients with pathological fractures, or polytrauma patients requiring multidisciplinary interventions, because in these patients, we opted for Ilizarov fixation. That means the external fixation. Now, I would briefly describe the surgical technique for the Lobenhofer approach. For as far as anesthesia is concerned, almost all of these patients were done through spinal anesthesia. A few were done through epidural, and maybe 1 or 2 patients with general anesthesia. Normally, spinal anesthesia is the anesthesia of choice for such patients with minimal risks of complications, but this also depends upon patients' choice as well as their discussion with the anesthetist. Regarding the patient positioning, I would just describe the patient's positioning. The patient would lie down on the bed in lateral position. At the level of the shoulder, the patient would be in a pure lateral position with one arm down, the other arm on top of it with an arm pillow in between the two. As we move down onto the patient at the level of the groin, at the level of the iliac crest, we would have the patient slightly tilted towards the opposite side. The side to be operated upon was kept on the top. And lower down, the leg was further rotated internally so as to expose the back of the popliteal fossa. That means beneath the mid-thigh downwards, the patient was sort of totally prone while still being in the lateral decubitus position at the level of the abdomen, chest, and at the level of the shoulders. Digital pneumatic tourniquet was used in all of these patients. That was inflated after the patients had been draped. We routinely used the conventional clothes drapes for these sort of fractures. And the folio drapes aren't bad as well, but I mean, there is no specific consideration that we took into account regarding the drapes. Now, for as far as the dissection is concerned, with the patient totally prone at the level of thigh downwards, we would give an incision in the form of an inverted L. The vertical limb of the L would run along the medial edge of the tibia, along the medial calf. And as we reached the popliteal fossa, we would gently curve it along the popliteal groove for nearly half the length of the popliteal fossa. And that would constitute the transverse limb of the inverted L incision. Going downwards, we would incise fascia, subcutaneous tissue, and then we would reach the facial layer covering the gastrocnemius muscle. We vertically incised the facial layer in the gastrocnemius muscle, and then we would gently mobilize the entire gastrocnemius muscle laterally, and we would work our way down medially, and this would be the interval in between the gastrocnemius and soleus muscle complex and the hamstrings being medial to it. That means the semitendinosus and gracilis being medial to it. The plane would run in between these two muscle groups. And running downwards, we would go all the way up to the intermuscular septum, still moving downwards, and laterally we would reach the posterior medial edge of the tibia. And there, with the help of periosteum elevator sticking to the bone, we would gently sweep the periosteum all the way up to the lateral edge of the tibia, and then pass a blunt home end retractor towards the opposite side. That means reaching all the way up to the lateral end of the tibia. And then with the help of blunt dissection through the use of artery clamp and through the use of periosteum elevator, we would normally do the blunt dissection distally as well as proximally. Proximally, we can do the dissection all the way up to the level of the joint. If needed, we can sort of open up the capsule of the knee joint posteriorly, specifically posteromedially. And distally, we can extend it for quite length as much as is needed. Now, for the reduction, uh, first of all, we would identify the fractures, and with the help of small gauze pieces, and with the help of a small curette, we would take off the blood clots, and so as to clean up the bony edges. And the technique which we use to reduce such fragments, we use a small bolster that is kept underneath the distal femur onto the table. This also lifts the entire leg slightly up, and then we would take the leg into hyperextension, so as to produce some recurvatum along with manual traction. Most of the fractured fragments would fall into their place with the help of this maneuver. Those fractured fragments which are difficult to reduce or are not being manipulated, we used the joystick maneuver using a small shank span or a small K wire, and then we temporarily fixed the fractured fragment with the intact proximal edge with the help of single K wire or a couple of K wires. In a fewer cases, we also utilized large reduction clamps, which I have made for the proximal tibia, which have a small blunt tip at their end with a small ball-like extension just distal to it, so as to apply compression to the plateau. That similar sort of reduction clamps I've also used for the posterior proximal tibial plateau. They add to the compression, and they also avoid sinking of the compression forceps into the cancellous spongy bone at the level of the proximal tibia. The reduction is confirmed visually at its posterior and distal edge at the level of its junction with the cortical bone, but at the level of the inside the knee, I mean, we cannot visualize the reduction. For that purpose, what we do is we always take fluoroscope C-arm images, both AP and lateral view, at the level of the articular surface. However, the reduction at the other edge is visualized and is clearly seen, and one can appreciate it. What we do is we normally fix these fractured big chunks with the help of a locking buttress T-plate. What we do, we normally apply a cortical screw just distal to the fracture, and the bend of the plate gives the buttress to the fractured fragment. The proximal posteromedial tibia also is slightly protuberant, just like the bent portion of the T-plate, which we normally use, the locking T-plates. But the protuberance of the tibia is slightly more compared to the T-plate. So when we tighten the screw, the buttress of the T itself adds to the fixation and stability of the proximal posteromedial fractured chunk. I almost always add a couple of screws to the fractured fragment also. And in a fewer cases, I have also used maybe a single screw or two screw from outside of the plate. Because in certain cases I have placed slightly lower down from where I anticipated, and once I fixed it, I took few images, so the plate was slightly lower down, so I added a couple of screws above the plate. So I mean, we can also pass the screws from outside the plate as well. Once the fixation is achieved, if it is an isolated posteromedial chunk, what we do is we cover it, we compress it with gauze pieces, we release the tourniquet, we take care of all the small bleeders which tend to bleed, and then we close it in layers. I normally do not put in any drains. and apply slight gentle compression for a couple of days, and then the compression is released. For as far as the neurovascular bundles are concerned, in this particular approach, we do not need to isolate the nerves, vessels, and arteries. What we do is we follow the strategy of sticking to the bone. We reach up to the medial edge of the tibia and then take away all the structures along with the gastrocnemius. We do need to lift off some proximal portion of the soleus muscle from the back of the proximal posterior tibia, and then the neurovascular bundle along with the gastrocnemius and soleus is pushed off laterally, and they are not vulnerable to any damage. But it is always safe to avoid using any sharp knife or diathermy, especially if it is at high voltage, because it can produce some burns to the structures nearby. So one has to stay blunt while working in that area. All right, so for the isolated posteromedial fractures, what we do is we close the patient in the same semi-prone position while the patient still is in lateral position at the level of the shoulders, and then we close the patient. But in our 15 patients, 12 patients had biocondylar fractures. What I mean is, along with the proximal posteromedial tibia, the patients had fractures of the lateral plateau with some and the fracture of the plateau. So this lateral positioning is also very helpful, because in prone positioning, one cannot sort of turn the patient supine for the lateral plateau. Here, the patient is already in the lateral position. Using same drapes with one assistant at the level of the shoulder, and one surgeon takes hold of the other leg, which is underneath the drapes, and we can gently tilt the patient back to the supine position. And if needed, we again, we reinflate the tourniquet, and then we deal with the lateral plateau. So in this way, in a similar set, in a single setting and with the same drapes, we can take care of both the plateau, and that too in probably nearly 1 to 1.5 hours, 2 hours maximum, depending upon the comminution pattern and the anatomical configuration of the fracture in itself. The skin is closed in layers, and then we apply a knee immobilizer with a bandage on the top of it. I have I'm showing a few pictures of the proximal posteromedial tibia. While this particular plateau is a pretty big plateau in this particular case, normally what we encounter is we normally encounter half of the medial plateau, and that too goes posteriorly and sinks slightly down. And that is not amenable to fixation from the medial side, because if we apply a T-plate here, at the most we will be able to add only a single screw in this posterior half of the plateau. I have another case in the next slides which I'll show you. All right, so this is the position. The patient on the top is in the lateral position, while from here downwards the patient is tilted and is totally prone. This is the vertical limb of the incision, and then this is the horizontal limb of the incision. As we go down, we can see the gastrocnemius muscle fibers running over here. And since this is the medial edge, we will have the hams running down over here and then going and inserting over the anteromedial tibia. I'll show you in the next few slides. So here it is. This is the gastrocnemius, and these are the fibers of soleus taking their origin from the proximal posterior tibia. And as can be visualized, these are the hamstrings. So we have to make an interval in between these two. And while going down, so in this particular case, this is the medial side. These are the hams which can be seen over here. And this is the gastrocnemius, two Homan retractors. The spike retractors are applied onto the lateral tibia. The gastrocnemius along with the entire neuromuscular bundle is retracted laterally. This is the bony fragment which needs to come down here. As I mentioned, producing recurvatum, hyperextension at the knee, and compressing it down with the help of either a periosteum, a blunt periosteum, or with the help of a compression clamp. This helps, this is reduced. The reduction is confirmed at C-arm as well as on visual inspection, and then temporarily fixed with K-wires. So now this is that particular type of fracture which I was mentioning. This is the big entire chunk of the proximal posterior tibia. So we approached it posteriorly, applied two temporary K wires, and then we added a buttress of the locking plate along with the screws through the plate as well. So this is the lateral view. The reduction of the lower edge is confirmed visually, while the reduction at the level of the joint, because this is indirect reduction, one cannot visualize it. Even while we have opened it from the back, we have to take C-arm images as to confirm the reduction. So once the reduction is confirmed, we fix it with the proper plate. Right. So for the follow-up, the patient normally is kept in our indoors for a couple of days. We give routine antibiotics and routine analgesia, nothing fancy. The patient is applied passive range of motion with heel slide on the bed alone with the help of an assistant, almost all the way up to 90 degrees for the first 2 weeks. We do not enforce more than that so as to allow time for soft tissues to heal, to allow for the edema to settle down. And the patient is asked for a daily change in dressing for the first 2 to 3 days. And then once the dressing is completely dry, we ask for a dressing change on alternative days till the time we see the patient at 2 weeks. The patient is then re-examined at 2 weeks. The wounds are checked, the stitches are taken out, and then we ask the patient to complete the range of motion in the next 2 to 4 weeks. I normally do not see the patient at 4 weeks. I ask them to come back at 1 month after 2 weeks, but the patients who are a little slow regarding getting their range of motion back, or any patients with comorbids or whom I feel like it would be better to see him at another 2 weeks, I call them at 4 weeks. For the first 6 weeks, the patient is allowed to start mobilizing, but that mobilization is non-weight bearing with the help of either the two crutches or with the help of a walker frame while keeping the operated side lifted up. I do not allow them to weight bear for the first 6 weeks. From 6 weeks onwards, with the help of walker frame or with the help of two crutches, I allow them touch toe weight bearing, gradually progressing towards almost complete weight bearing in around 3 months. And likewise, 6 weeks, 5 to 6 weeks is my time which I give to the patient to complete the range of motion at the knee. And Alhamdulillah, many of my patients, because of my extra motivation, they do give good ear to my advice, and they ultimately end up getting good range of motion at the knee. Then I re-examine the patient at 5 months so as to check for union, to check for any complication, to check for completeness of the range of motion. And then the final examination is at 1 year to check for the complete parameters of my study, which include I check for the union, I check for the range of motion at the knee, I check for development of any arthritis at the knee, any stiffness, and such parameters. Now, my study. I took 15 patients. These patients had an age range of 18 to 56 years with a mean age of around 37 years. Surprisingly, all of my patients were male, and the right tibia was fractured in 9 of my patients, left tibia in 6 of my patients. Road traffic accident was the cause in 11, and fall from height or fall at home or at road while walking was encountered in 4 patients. Bicondylar fractures with one element of the bicondylar being a posteromedial fragment. These were encountered in 12 patients, and they were treated with dual plating. That means one plate over the posteromedial tibia and the other plate over the lateral plateau. And 3 patients had an isolated posteromedial tibial plateau fracture with an intact lateral plateau. So they were fixed with a single plate through the back. We did not encounter any perioperative or any immediate postoperative complications like nerve palsy, skin breakdown, or infection, etc. The average union time was nearly 3.5 months, nearly 4 months. Evaluation at follow-up at 1 year revealed 100% of our patients achieved union both clinically and radiologically. Full range of motion and ability to squat was noted in 11 patients, while 3 patients had a slight loss of flexion at the extreme. That means they could bend their knees from 0 to 120 degrees, and one patient had an extension leg of around 5 degrees. For as far as the difference between single and double plating was concerned, there was no difference in outcome. We have mentioned it, but technically we don't need to compare these two things, because the double plating was for the bicondylar fractures and single plating was for the fracture of a posteromedial plateau alone. There was no secondary loss of adduction, and grade 2 osteoarthritic changes were noted in only 2 patients at 1 year follow-up. So this is the fixation of only through the using and showing the complete range of motion at around 5 months. Now, Liu found out that with Lobenhofer approach, such fractures are reduced more anatomically And apart from anatomical reduction, they are buttressed with a more stable construct which allows for immediate early post-operative range of motion. Barry and Sinha, they found that with conventional techniques of plating, stable buttressing or fixation is not provided to such fractures. Zhang compared various modes of fixation for posteromedial fragment like the lateral locking plate, the anteromedial plating, the anteroposterior lag screw fixation, and the posteromedial plating, and noted that the posteromedial buttress plating was biomechanically more stable than the others. Lobenhofer, who basically for the very first time in 1997 published an article about his approach, who is the pioneer of this research, he revealed similar results. Shandale and Balochia had similar outcome in terms of knee range of motion, but in their patients, they have noticed 4% loss of reduction in contrary to our results where we had no loss of reduction. Arjuna, Gimenez, and Cleagues carried out study on 14 patients and reported similar results as per Knee Society score. They conclude the Lobenhofer approach was an easy approach with minimum complications. So conclusions. Accurate anatomical reduction and excellent functional outcome can be achieved by fixing posteromedial tibial fractures through the Lobenhofer approach in lateral decubitus position. It is a safe approach and has no major peroperative and postoperative complications. We recommend this approach for all proximal tibial fractures with a reasonably large posteromedial fragment. The limitations of our studies include we had a small sample size, 15, although the various articles that we went through also had similar sample sizes because this routine normally is not done very routinely, and the fractured fragments normally are not so big enough so as to warrant a fixation from the back. So, but obviously it would be better to have a study done on larger samples. And we had a shorter follow-up, and post-operatively we used radiographs rather than a CT to assess for the post-operative reduction assessment. For future recommendations, from 2019 onwards, after these 15 cases, I think I have done another 15 cases. So probably a larger sample and a study at more than one center, that means a multi-centric study and a longer follow-up, and as well as reduction assessment with the help of a post-operative CT scan would be the things which would add to the strengths of study which need to be carried out in the future. No conflict of interest, and there were no grants and funding from any sources. So these are the references. Thank you very much.
Thank you very much, Dr. Imran, for the elaborate description of this study. So now I will request our mentor, Professor Syed Mohammad Awais. He has a vast experience in treating orthopedic trauma patients. So over to Professor Syed Mohammad Awais for his comments on this study.
Thank you, Dr. Aisha. Can you hear me?
Yes, sir. We can hear you.
Okay. First of all, I'm very, very happy to listen to the presentation of Dr. Imran Kasrani. He has made a very, very good overall impact as a scientific worker. The paper which you have selected for discussion is of very significant importance in the field of traumatology. And this fracture has been neglected for a long, long time. As Lobenhofer made his recommendations in 1997, so before 1997, these fractures were not tackled in a very scientific way. So I congratulate Dr. Imran Kasrani, Dr. Kasrani Jr. We are very pleased about your scientific approach.
Thank you, sir.
The areas which remained a little silent to me was number one was the objectives of the study. And at the end of the day, whether those objectives were achieved in the study. And whenever we talk of science, we talk of objectives and we talk of hypothesis. And with relation to that, we measure the advancements made in the field. And with that measure, we also categorize the new knowledge as how much the new knowledge has been able to advance the existing knowledge. So that area, I know that that is in our clinical research, that is not a very easy thing to do. But I'm sure that in future and due course of time, our these very, very young experts, now these experts are not old in age, but they have a very vast experience, like this very rare fracture. Dr. Kasrani has reported more than 15 cases, which he qualifies in now sharing this experience with others. I think that the data which he has shown has given a lot of positive effect or influence on proving that it's better to whenever you see a proximal tibia fracture, it is always good to apply two classifications, short cut and whole and more. And when you are fixing it, then you must be familiar with the global approach. Obviously, you should have enough good implants. And like Dr. Kesani said, that it is always good for science to use post-operative CT scan. So with these very few my own personal views, I congratulate Dr. Kasrani Jr. and editor and editorial secretary for organizing this very, very valuable first Zoom meeting journal club. And I know that this will have a very good impact on other surgeons and in the scientific field. Thank you very much.
Yes, thank you very much, sir. So we have a few hand raises from the attendees. I will request Dr. Mujahid Jamil. He has raised his hand on the meeting. So if he has a question, we can unmute him and take his question.
Assalamu alaikum.
Wa alaikum salam.
Thank you very much for giving me the opportunity to raise the question or comment. I congratulate all of you for this wonderful activity, and it is very nice to see all of you, especially Professor Awais, after some time. So this post-medial approach which Dr. Kasrani has presented is a very useful approach. And it is, as Professor Awais said, being neglected because we usually tend to do tibial plateau fractures in supine position with either anteromedial or anterolateral approach, and this fragment is usually neglected. And the reason it is neglected is, number one, we usually tend not to do CT scans. It is coming into the culture now, but it is still less frequently done on these important fractures, which is the involving the weight-bearing knee joint of the body. So I think identification of the posteromedial fragment is the first important step towards a good treatment of this fracture. Once that is done, usually when you talk about posterior approach to the knee joint, it creates and provokes a little bit of anxiety because there is neurovascular bundle associated with it. So over here, I would comment that although Dr. Kasrani has presented some photographs of his approach, it would have been a little better to have a schematic diagram of how it is done, so that people who are trying to learn this approach will be a bit more clearer as to how it is done. And once the gastrocnemius belly is identified and correctly lifted onto the side of the neurovascular bundle, then there is nothing to worry, because it will nicely buttress everything behind the knee because of its bulk. So a schematic representation of the approach plus a few diagrams of, as he was saying, applying a first screw, then temporary K-wire, then buttress plate would have been a bit nicer for people who will try to learn this approach. Because once you learn it and you do it in 1 or 2 patients, you would love to do it, because it basically restores almost all of the knee joint. And then you will get to know, okay, is there a plate actually required on the posterolateral or the posteromedial side? So worth presenting the series. Congratulations to all of you, especially Dr. Kasrani. And I hope that this activity will prevail. And inshallah, we will contribute always and we will make it better.
Yes, thank you very much, and rightly pointed out. And inshallah, in future presentations, we will make it more of pictorials, so in order to get a keen attention of the participants. So we are also pleased to have amongst us the General Secretary of Pakistan Orthopedic Association, Professor Irfan Qadir Sahab. So I will request him for his final comments. Professor Irfan Qadir.
He is left.
Okay. Okay, so do we have any further? I have one question from Dr. Imran. So I want to know if you found any need to arthroscopically see the knee for any potential ACL, PCL, or meniscal injury in these patients.
No, madam, I did not do an arthroscopy. I do arthroscope routinely, but in these particular patients with bad fractures, what I tend to do is I normally fix them in stages. If needed, arthroscopic ACL or further fixation is done. And I may also add here that for the fixation of the PCL with the bony chunk from the back, almost a similar approach is used in which with the help of screws, we do fix the bony chunk of the PCL onto the posterior tibia. That is the Burks and Sheffers. That is slight modification of the Lobanhofer approach, and I have done quite a lot of PCL with the same approach. But as you have asked, I don't scope them and don't do ACL in the
So
same
none
setting.
of these patients had post-op ligament problems?
No, I did not encounter.
Okay, thank you very much. So we have Professor Ghulam Mahmood Saab and Professor Eid Mohammed Saab.
Excuse me, Dr. Aisha, I think, okay.
Dr. Faiz?
I was just asking the same. We have Professor Ghulam Mahmood Saab. I think we can take his expert opinion.
Okay, so we welcome Professor Ghulam Mahmood Saab, and if he can unmute himself and further enlighten us on this topic. We have few minutes before we will close.
Assalamu alaikum. Are you hearing me?
Yes, sir, we can hear you.
I think unfortunately I joined very late, and you are discussing the last part. Secondly, after Dr. Weiss, it is I don't think that it is somebody will talk a lot. So I think it was a good topic, and he has done very good. Congratulations to Dr. Senior as well as Junior Kasrani, who has been our friend. And I think you will continue this activity with this. I think I say goodbye to all of you.
Thank
you very much, sir.
I think we have Professor Eid Mohammed Saab, who is President Pakistan Orthopedic Association. Is here. We can ask his comments. Eid Mohammed Saab. Do you hear us?
I think he has also left. I talked to Dr. Irfan. He might join us in a few couple of seconds or minutes. So there is a hand raised
Okay.
by Dr. Asif Paracha or some other participants also.
Hmm. So we have a few more minutes before we close. If someone has a question, so we have two hand raises. Dr. Paracha has raised his hand, so can we unmute him and take his question or comments?
Yeah, sure, we can take.
Hmm.
Dr. Asif, can you hear me?
Yes, Dr. Kesani, I have one question from you. As you said, after putting butter plate, but you want to put screws in the proximal part of the plate. Suppose if there is some displacement in the you say in the coronal plane, and you want to get compression in the condense, so then how will you get it?
To get compression at the level of the articular surface, what I did was I hyperextended the knee. This produced
No, no,
space.
no, no, no. My question is that suppose you put for this sagittal fracture, you put the plate on the posterior aspect, and you said you will put screws in the fracture fragments as well. But suppose if there is some displacement in the uh, simply if the anteriorly in the APV you see some displacement is there, then how will you reduce it? Because now you have already closed the wound and you put the screw as well.
Sir, I always take images before putting on the plate. I always ensure reduction with the help of wires. And once I have reduced it anatomically, only then I would add another plate. In a fewer cases in which the fragments was such that if I added a lateral plate and I added longer screws, that would probably hinder the reduction. Or likewise, if I added longer screws from the back, that might add to some difficulty with reduction laterally. What I did was I did both of these approaches simultaneously. I turned with the patient totally prone. We did the posterior work, and then we, in the similar position, we just rotated the leg to bring it to the lateral position, and then we would do an anterolateral approach. So I would add smaller screws, add screws from the opposite side, and then convert them to full-length screws.
No, actually, this is my opinion and not comment. This is my opinion that
Sure.
if you put only a butters plate, that is enough. And I don't think so there's any additional benefit of putting a screw in the fracture area. So you just put a plate on the butters plate you did, and then you change the position and you then apply a lateral plate. This is just my idea as I am doing like this.
All right, sir. What one can do is one can add smaller screws, or it is very right. One may not need to add screws if you have gotten a very good buttress. But I always take images and I almost always add screws. Basically, I want full tasalli of the fixation. So that's why.
Yes.
Very right.
Okay.
Done this way. Very right.
From Professor Noor Akbar Syal Sahab. So we can also take his question, and then we will take the concluding remarks from General Secretary of Pakistan Orthopedic Association. Professor Noor Akbar, if he can unmute himself and,
Yes, are you listening me?
Yes, we can hear you.
Congratulations, Dr. Asha Said and all seniors. Very nice talk. This was just comment. How you will tackle the long fractures which extends up to the shaft in certain heavy, that's high force trauma. Then what is the option? You are applying plate posteriorly. So there are a lot of soft tissue structures and subcutaneous approach and subcutaneous facility. Usually you are avoiding that. How you tackle this such sort of cases, polytrauma or all that?
Sir, for the fractures which are just like the ones I mentioned, with the posteromedial fragment, I have never encountered such bigger fractures. Very true, then it will be very difficult. But for bicondylar fractures which extend distally, I have almost spanned the entire tibia through MIPO with only a couple of stitches at the top and couple of stitches distally. For the posterior posteromedial fragment, I have never used very big plates. Neither have I used MIPO over there. So probably I'm yet to see such patients, and once I see them, I'll see what I'll do, because it will be definitely a difficult task. Probably what we can do is we can add a smaller plate and fix it with the screws so that it doesn't fall back, and then the remaining length could be spanned either enteromedially or enterolaterally. Probably that could be one of the answers, but I haven't extended this approach so as to say beyond the junction of proximal and mid third of the tibia posteriorly.
Thank you, Ji. Thank you.
So there's also a question from Vasik. He's asking, he's actually saying that most of the surgeons are now using Elizarov to fix intra-articular fractures like these. So what is the advantage of your approach over Elizarov?
That's a very nice question. For Schatzger 6 or for very bad proximal tibial fractures, I almost always did Elizarov at one stage of my career. But I have seen that patients always have issues with Elizarov. The issues of wires getting infected, a few wires breaking, and even if they end up right, the patients still have issues with their clothes tangling around with the wires and chains of Elizarov. So as to say, they're not very comfortable while they have their Elizarov on. So fractures in which I can plate, I always plate. But for the fractures with bad skin, with tight compartments, or with the ones with likewise, as I said, with polytrauma, I have to fix many things, I do Elizarov them. Elizarov is my second option in such cases, because one may be able to add a wire through posteromedial towards anterolateral to fix this fragment, maybe a couple of wires, but then the ring of the Elizarov would add as a hurdle to complete range of motion. And as I said, the plates are very patient friendly. The patients are very comfortable with plates inside, with nothing outside, getting good range of motion and getting good union with good reduction. So even for these fractures, I played them whenever I could, although I do Elizarov as well.
Okay, so I'll request Professor Raja Irfan Kader, who is the General Secretary of Pakistan Orthopedic Association, for his comments on this activity and on the paper discussion. I think we have lost him. So there's a final hand raised from Dr. Tashfin. Kindly, if you can ask your query.
Assalamu alaikum, everyone. And I would again like to congratulate JPOA and the presenter on this first event. What I have noted is that local literature, such as the one presented by Dr. Kaisrani, is often not mentioned in our city meetings, our monthly meetings of the POA. And therefore, our community at large in Pakistan is not aware of how much excellent work is being done by different people across the country. Our journal is in the process of getting indexed in PubMed, but until that is done, perhaps we could consider supporting the monthly meetings by providing them the literature already published in JPOA on the topics that are going to be discussed. And perhaps we can reinforce this with the coordinators of the monthly meetings, that we will be able to support them in an extensive literature review from the local literature. Thank you.
Yes, thank you very much. That's a valuable opinion. And definitely we need to increase the citation of local authors and local researchers. Okay, so with this.
From Dr. Eid Muhammad, you can ask him.
Okay, so we'll take final few words from Dr. Eid Muhammad, who is President, Pakistan Orthopedic Association.
Hello, thank you.
Actually, he's doing.
Madam, can you hear me?
Yes, we can hear you, sir.
Thank you very much. I'm very grateful to Dr. Kaisrani for his good presentation. This is good gesture for our orthopedic surgeons all over the country. So this is a good start. I congratulate him and the whole team. One thing I want to say is when we were here to start the meeting, we had a link with Peshawar webinar. So another meeting was going on in Peshawar that was conducted by Dr. Sikandar and Dr. Saeed. So we had two connections. So kindly do the job to do a single meeting, and this is for the benefit of the whole arthritic community. So make a unity, and this is the job of our General Secretary to stop the meeting in Peshawar, please.
Okay, thank you very much, sir. So you're right. We will make sure that we have better time management so that people can join in. And definitely all of these meetings are recorded as well. So the residents and the fellows, they can always go back to the YouTube channels and watch these meetings again at their ease as well. Okay, so with this, I conclude this meeting. And thank you very much, our esteemed panelist, Professor Syed Mohammad Awais Saab, for his time, his kind opinion, and his keen participation. And of course, Dr. for contributing to the first virtual journal club with his very original kind of research paper. Thank you very much. And of course, to all the team.
Thank you very much, Dr. Aisha, for keeping the time. Allah Hafiz.
Okay, see you inshallah next month with another virtual journal club.
Thank you very much, madam.